Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our up-to-date series in MRCOG. This series um, is focusing on the updates of the college, whether it was a guideline or of course important talk articles. And today inshallah we are going to talk about the update of herpes simplex virus in pregnancy. As I told my candidates before, it's not really an update, but the college has archived its guideline and referred to the PASH guideline for the management of herpes simplex. So now we are going to review the PASH guideline for HSV, and they have updated their guideline recently this year. So let's see what they are saying. First of all, this one, in means of etiology, percentages, and so on, is much more organized. And I think, of course, any number can be exam question. I'm going to tell you what was the exam question that appeared before regarding percentages. But in general, yes, sure. In general, you should take care of epidemiology. Epidemiology is a part of your curriculum, and you should be aware of the important numbers. Like, for example, when they started talking about the etiology of herpes, herpes has many types and also have many ways to be transmitted. Not all of them carry the same prognosis. Not all of them has the same weight. So you as a doctor, for counseling your patient, giving her a good advice, you should know which type she's having and what kind of infection she's having now. Is it active? Is it primary? Is it recurrent? And so on. So let's see. The recent surveillance in the UK, neonatal herpes approximately was almost equal between HSV 1 and 2. We are talking about 52 to 48. So there is no huge difference. But still, HSV 1 is more common. The most common way for transmission is direct contact with infected vaginal secretion at birth. This could be, of course, SVA. So what we fear of is a woman who is having a primary active acquisition near term, specifically speaking, in the 6 weeks before birth, right? Or up to 4 weeks postpartum. I'm going to tell you why. The reason why we should take care of postnatal acquisition is it is the second common way that the baby can get the virus, 10 to 25%. And this could happen by direct contact from relatives, from the mother, from the parents, from the healthcare worker. Herpes can be transmitted only skin to skin contact. We don't need to have mucosal secretions. Okay, so this is why the amplification of this virus is great. I maximized the screen. You can maximize from your phone or your laptop too. But this is the maximum here. Okay, so number one, I should know the most common way of transmission. Number two, I should know the median time of presentation. Why? Because this is crucial in diagnosis. How? When your patient comes to you while the baby is still in the first 8 days of life, this is usually local infection. So carries better prognosis. Of course, mortality is almost 0%. Yeah, morbidity is around 6%. but mortality is 0. Why? Because there is no CNS or visceral organ involvement. While if the baby showed symptoms, median time around 2 weeks after labor, we are talking about CNS involvement. Neurological morbidity is very high. And usually they are going to present with seizures. Usually this is going to be HSV, herpes simplex virus 2, not 1. Usually those are the pregnant ladies who didn't receive the treatment in the right time. They had delayed time to antiviral treatment. If the baby present within 6 days with fever, or let's say sepsis, we still don't know what's going on, sometimes with seizures, the patient is going to tell you, yes, I had a history of herpes. This baby could be having disseminated disease. The worst prognosis, of course, long-term morbidity, 41%. So again, I think this is very important in EMQ scenarios. You should know that mortality is more frequent with type 2 more than type 1, while type 1 is a little bit commoner than type 2. This is also very important to know because you are going to do a PCR and discover what type of herpes she's having or the baby's having. I have put in comparison the 3 of them, okay? So it's going to be easy to revise. Number 3, the timing of acquisition. When the mother had her first episode of herpes. This is why we always focus on primary herpes versus recurrent, and primary herpes in which trimester? Is it in the first trimester or the second or the third? Is it going to have any amplification? Yes, definitely. Because in first trimester, there is no increased risk for spontaneous miscarriage, no increased risk for anomalies, okay? And usually the mother is going to develop the antibodies, transfer it to the baby, and she can have a vaginal delivery. We have time. But second and third trimester are very tricky. Why so? Because second trimester acquisition sometimes mean danger for babies who are going to be born prematurely. Who knows? Maybe this baby is going to be born by 32, 34 weeks or less. So there is no time for developing the antibodies. This baby is going to have a problem. So do you remember the old numbers? The old number that we used to tell our patient during counseling? That if she got the herpes in the first trimester, even if it's primary, there is 0 to 3%, okay, for transmission to the baby at the time of vaginal delivery. And of course, if she's having recurrent, there is no risk for congenital abnormality. While if she got a primary episode at the time of delivery and the baby was delivered vaginally, the risk is 41. 41 means this baby could be having a local disease or CNS or disseminated according to his luck and his immunity. Okay? So he's going to get one of those by 41% risk. If she is not primary, She's having non-primary episodes. Sometimes she previously had one type of herpes, and now she's having the other type. And this is around birth. The risk is estimated 25%. This is new somehow, or let's say more clear than the previous guideline. And it's a good opportunity to tell you the difference between primary, non-primary, and recurrent. I don't need to tell you that, of course, preterm babies are going to have higher risk. And of course, they are going to have high risk for disseminated herpes. The lower the gestation, the higher the mortality. So this is why they changed the prophylaxis. This is the major change in this guideline. Transmission, which was beautifully detailed in the PASH guideline. They classify the genital herpes infection into mainly two families: initial episode and recurrent episode. But the initial episode could be primary or non-primary. Primary means that this is my first time to get type 1 or type 2 herpes simplex. The first time at all. Non-primary means I may have got herpes simplex virus before, but now in pregnancy, I got the other type for the first time. So I'm having antibodies for one type, like, for example, previously I got HSV1, and I have antibodies for HSV1. My baby is going to have those antibodies, but for some reason, I'm very unfortunate, I got HSV2 from my husband, from a relative, from whosoever. Skin-to-skin contact, not only by sexual contact. So I got it. Now I'm having initial episode, but it's non-primary. Still, there is a risk for this type of infection, as I told you. This type of infection here, if it happens at birth and the woman is having a vaginal birth, the risk for neonatal transmission is 25%. Of course, those numbers could be SBA. This is old number and everyone know it. 0 to 3% is old also. We all know it by heart. Very important during counseling also. Regarding recurrent infection, that means the residual virus that usually they are dormant in the nerve endings. They're going to be active again because pregnancy is a state of low immunity. So yeah, okay, I'm going to have a recurrence of symptoms, but of course, the neonatal infection or the risk for my baby is much, much less than someone who had his first episode around labor. Okay? I'm going through your question. 0 to 3 is the risk of neonatal transmission if the woman is having recurrent herpes and she had a vaginal delivery. 25 is for non-primary infection. Non-primary infection is not recurrent. So yeah, you got to try it in the second time. Excellent, yes. In the second time, you got to try it. Excellent. 41 for the primary, 25 for non-primary, 0 to 3 for the recurrent infection. Excellent. Okay, now we know our risk, our prognosis, everything is good. What about late presenting mothers? You know who are they? This is someone who got her symptoms like up to 4 weeks following birth. She got her symptoms apparent, she got the rash or the vesicles or whatever after having birth, up to how many weeks? 4 weeks. That means that the baby, of course, was at risk because she got her first episode around labor. So she must have shed the virus at delivery. This is not classic, of course, but it can happen. And we should treat this baby as highest risk neonatal case. Is my voice clear, guys, or only Dr. Onika, she is having the problem? Is my voice clear? Okay, thank you. So take care because this would be a very tricky case. Because you are always due to see if the mother got the acquisition in the first or second or third trimester. Now the mother is presenting postpartum. So how I'm going to deal with her? Deal with her as if she got her primary episode at labor. The baby is now classified as the highest risk neonatal case. This is, for, in my opinion, very, very important. Now the routine prophylaxis, which is the major change in this guideline. Previously, when a woman had frequent recurrent episodes of HSV, we used to give her a cyclovir from 36 weeks. Yes, she's having a recurrent infection, but being frequent, there is still a risk for transmitting the virus to the baby. Maybe, as I told you, it could be another form of the virus or another family. So we should be safe. What we used to do is to give her a cyclovir from 36 weeks until delivery. Now they are telling us, if you are having a woman with frequent recurrent episodes, you should offer her the acyclovir from 32 weeks. You all know that recurrent episodes usually does not need treatment. Usually they are self-limiting. Usually they take from like 7 to 10 days to go away by themselves. Only symptomatic treatment, some lidocaine, gel or ointment. If she's having pyrexia, she can take paracetamol and so on, soothing pulses, and that's it. But for the protection of the baby, please remember that you should offer her prophylaxis now from 32, not from 36. Now, if the woman is having increased risk of preterm delivery and she is used to have frequent recurrent episodes of HSV, you should start the prophylaxis from 22 weeks. I remember, I usually tell you stories like this to make you remember in the exam. I remember a school friend of mine. She was really kind, but she always get oral hurts, always. Like every 3 weeks or something. She got the vesicles around her oral cavity. This is a kind of a woman. When she get pregnant, I would offer her the prophylaxis from 32 weeks. And if she got any signs or risk for preterm delivery, I'm going to offer her the prophylaxis from 22 weeks. For example, she started to get contractions from 24, 26. I'm going to start it from this week. Why? Because she is having a history of recurrent oral herpes. You got it, guys? Of course, if she's having recurrent genital, definitely, I'm just giving you an example. So the prophylaxis is the major change between the previous and the current guideline. Management of disseminated infection in adults. Our mother, our patient, who is perinatal or unwell or having low immunity is having a high risk to develop disseminated infection. This could be emergency case. We need to send samples, of course, samples of blood, of the skin lesions, CSF, any body fluid for urgent PCR, and of course the antibody. And we are going to give her high dose IV acyclovir. High dose means 10 milligram per kg. This is huge. Three times. Three times. So you are going to calculate 10 milligram per kg and she's going to take it 3 times per day. And don't wait for the results. You should start treatment once you get your diagnosis. Okay? Let's continue the management. If we got acquisition at any gestation, general rules. The general rules are when your patient comes to you in the antenatal care clinic at booking, you should talk to her about the importance of maternal infections and how she should be safe and whether she got the herpes before or not. She should take the pamphlets for maternal infection, be aware of the signs and symptoms. Of course, you are not going to tell her about only herpes. You are going to talk to her about sexual transmitted diseases, especially syphilis, the CMV, the parvovirus, everything. And take a careful history because we need to know if this woman is having a previous infection or not. This is going to make a huge difference in our management. If your woman presents to you with suspected genital herpes, we should refer her to the GUM clinic or the genitourinary medicine physician. He is going to confirm or refute the diagnosis and give us an advice on management. Of course, we have our algorithm, okay? But he is going to do something else. He's going to arrange a screen for other sexually transmitted infections. Also, he's going to take a PCR swab, a swab from the ulcers or skin lesions tended for PCR for varicella zoster, HSV, syphilis, even for lymph granuloma. If the woman is having ulcerative disease and you have any doubt, all of them are going to be done. The MPOX, of course. Full screening for chlamydia, gonorrhea, HIV, hepatitis B, and hepatitis C. Again, we shouldn't wait for the test results to start treatment. Once you have a definite diagnosis that this vesicle or this ulcer is herpes, by suspicion, you are going to offer your patient the treatment as follows. Those regimens are very important in the exam, guys, and they come as EMQ. So please take care of the dose and for the duration of treatment. We are talking here about someone who is having infection regardless of gestation, regardless of gestation. I'm very clear and loud here. Okay? We are just trying to reduce the viral load and shedding to the baby. We are trying to reduce the HSV shedding at term. So we are going to give her acyclovir 400 3 times for 5 days, or valacyclovir 500 2 times for 5 days. From what? From 32 weeks of gestation. Are we clear about this? No, don't wait for the confirmation of PCR. Don't wait for the confirmation. If the doctor in the GYN clinic agreed that this is hers also, it's going to be write it down in her report that she needs acyclovir from 32 weeks. This is the suppression dose. Okay, okay. Some notes to be taken. We talked about the general management, but this is going to be different with someone who had a third trimester acquisition. Because in this case, I'm not going to give that treatment only for 5 days. I'm going to give it until delivery. I'm telling you, forget about the old guideline now. Focus here. We started our suppression dose from 32 weeks, or maybe if she was at risk for preterm, we started earlier than 32 weeks. Right? If the woman got a primary acquisition in the third trimester, okay, or as I told you, she got huge lesions in the third trimester, could be primary or non-primary, we should continue until delivery. Okay, so take care of the choices of EMQ. Make sure about the timing of acquisition. Her primary or non-primary. It's not recurrent, okay? Well, I'm not talking about the recurrent now. The recurrent is having a suppression dose, okay? And we all know it. But it's not going to continue until labor. I'm going to give this woman who had a third trimester acquisition her suppression dose until labor. Are we clear? Sometimes the doctor in the GYN clinic is going to give us higher doses than this. It depends on her immunity state. We have women with adrenal insufficiency, diabetes, HIV, some autoimmune disorder that they needed to take immunity suppression disease. So they may need higher doses. Okay, this is our suppression dose or treatment. How you are going to treat the symptomatic first episode? By symptomatic treatment, supportive therapies, paracetamol, topical lidocaine. That's it. But the main idea of giving acyclovir or valacyclovir is to reduce the viral load that can be shed during delivery. HSV, guys, is not completely treated. It's always going to be dormant in the endings of the nerve cells. Okay, so you are not going to get rid of it. When we give the patient a cyclovir, it's not to treat her unless she's having disseminated infection, okay, or severe infection with severe symptoms, not only vesicles and ulcers. But the main idea of the suppressive dose, as I told you, is to decrease the viral load. As you can see, we shouldn't give the famiciclovir because there is lack of safety regarding this agent. Okay. I need to make sure that you got these points clearly. Here we have the birthing plan. Okay, you are going to tick over which regimen she has been taking. If she was high risk for preterm delivery, which one she was on. If she had preterm pre-labor rupture of membranes, the PPROM. Did she take a cyclovir IV? Did she need it? Or she only needed a cyclovir orally from 32 weeks or valacyclovir from 32 weeks? There is no such treatment dose and suppressive dose. It's not like this. It's not like this. Okay, if you want to call it like this, okay. But in disseminated infection, this is a critical case. This is ICU case. I'm going to tell you about the routes of delivery, don't worry. Okay, so as you can see, those are the antiviral suppression. You are going to tick over the one she has been taking. And if she wasn't taking anything, of course, you can tick here. Okay, now the planned delivery method, whether it's vaginal or cesarean section. It makes sense if the woman had her primary episode within 6 weeks of delivery, she should have a planned CS. It makes sense, of course, because there is no time for making antibodies. This baby is having high stress for neonatal herpes. So as you can see here, in the flow chart, we are going to recommend the CS if she had the primary acquisition within 6 weeks of delivery. Otherwise, we have time for the mother to develop the antibodies and transfer it to the baby. So if she got the primary acquisition in the first or second trimester, she is still a candidate for vaginal delivery, especially if she was treated. Okay? Those are the suppression doses to be considered from 32 weeks. And for those who have highest risk for premature delivery, from 22 weeks. Okay, your question about treatment or suppressive or so. Okay. We don't really give a cyclovir for recurrent infections. Okay, we only consider it when there is huge symptoms. or when the patient is having low immunity, and this is her first time to get the genital herpes. Otherwise, usually, she's going to have a cyclovir cream or gel. I'm talking in practice, okay? But if she's having vaginal primary acquisition, yeah, okay, you can offer her a dose of acyclovir for 5 days. This is different from the suppressive dose I was talking about. The suppressive dose is really important, guys. Don't conflict between this and this. I don't care about the treatment of the primary episode. Usually she's going to her GP and he's going to treat her for this. Our job, when we know that she got HSV in the second or third trimester, we should do something. Okay? If she got primary acquisition in the first or second, we are going to give her the suppressive dose. If she's not treated, if she is not treated and she got primary herpes in the second or third trimester, what's going to happen? She is going to be at risk for how much for neonatal transmission at birth? Those numbers. 41 if it's a primary episode, 25 it's non-primary. Now I'm talking about the number that was mentioned in the guideline. The transmission is 100, this is for sure. I'm talking about the risk of neonatal herpes. Okay, there is something is called viral load. The virus is going to transfer through the placenta to the baby. Just like the IgG. The IgG, the antibody against the virus, is also going to transfer to the baby. When the woman is having primary infection in her third trimester, especially around labor, without treatment, we are talking about risk of neonatal herpes 41%. This is huge. Now, another important table in this guideline you should know about, but let me first talk about the PPROM and PROM management concerning HSV. Okay, here we are. It is the same like the old guideline or the one that was present in the GTH. If she's having primary genital herpes and she got PPROM, number one, the baby is preterm. So this baby have the highest risk for disseminated infection. I need to ask myself one question. Is this woman is about to deliver? Is the delivery is very imminent? Or she just had a PPROM and there is no continuous contractions? Okay, so we are going to deal with her like any other PPROM lady. So if she was having the imminent delivery, not only PPROM, cesarean section, of course, is better than vaginal. Okay, we agree on this. If we still have time, she's not having continuous contractions, and we are giving her the conservative management for PPROM, give her IV acyclovir, 5 milligram, not a high dose, 5 milligram per kg every 8 hours, plus prophylactic corticosteroids, of course, just like any PPROM lady, plus IV acyclovir. Okay, if the delivery was expected to be within 6 weeks, we still don't really know. Again, think about cesarean section, not vaginal delivery. So this is the management of PPROM while the patient is having primary genital herpes. If she's having recurrent genital herpes and now she's having PPROM, this woman is already having antibodies. This woman, from her history, we know that she's having recurrent genital herpes. Even if she got a recurrent episode, the risk of neonatal transmission still low. And her main problem now is prematurity, not the herpes. So if the PPROM happened before 34 weeks, we can do expectant management, just like the NICE is saying, and we can consider oral acyclovir 3 times per day for 5 days. After 34 weeks, treat her like any PPROM case. And don't forget about the corticosteroids, of course. This is just like before. Good so far? So the woman with PPROM and primary genital herpes, consider CS, give IV acyclovir, prophylactic corticosteroids. Simply. MDT, of course, because the MDT is going to decide whether she needs immediate delivery or not. It's case to case, according to how many contractions she's having, if she's having HIV with already or not, does she have GPS or not, many factors. Okay? Now let's talk about the tables that is regarding the neonatal management. For recurrent infection. For recurrent infection, yes. She's PPROM. No. One time, one minute. We agreed before that any frequent recurrent episodes is going to need suppression dose from 32 weeks. Right? We already agreed on this. Okay. So here we are. The risk stratification for the babies is very important even for us as obstetricians. I think this could be exam question. For example, he could give you a scenario of a baby who had symptoms consistent with herpes simplex, regardless of delivery method. This would be tricky. You know why? Because all candidates are going to think that if he was delivered by cesarean section, then he is okay. He's not having the herpes simplex. Who said so? We are just trying to decrease the viral shedding. This does this doesn't mean that the baby is having 0% virus transmission if he was delivered by CS. So if the baby is having symptoms consistent with HSV, this is highest risk. Of course, like any baby who got positive HSV test, even if his mother was only suspected for HSV, just like a baby born by vaginal delivery in the presence of active primary lesions, right? Just like a baby, and this was the one that I told you take care of, this would be great question. A baby who had birth from a mother presented postpartum with active primary herpes within 4 weeks of delivery. This baby is having the highest risk and should have the highest care. I'm going through the scenarios that you are trying to imagine now. Okay, how you can imagine whatever scenario you want, but in the exam they are going to give you a clear one. Don't worry. Okay? Guess what? A baby who was born by CS could be high risk. You know why? Because his mother had initial HSV infection within the previous 6 weeks. But there was PROM, whether it was PPROM or rupture of membranes at term. This is going to make this baby having high risk. I wanted to go through those tables to make things clear for you. Both of those babies are going to be urgently managed and urgent inform the neonatal team for urgent assessment. Okay? The asymptomatic babies who was born by vaginal or cesarean, but there is active recurrent herpes lesion, they have low risk. But you should again urgently inform the neonatal team. Who knows? This baby could have low immunity and he may get at least local infection. Another important point, timing of investigation. Babies with highest risk are going to need urgent swabs. Others can be delayed 24 hours post-delivery, as you can see. Another important point is what type of swabs you are going to do. Any visible lesion, of course, nose, throat, conjunctiva, rectal. But the difference is lumbar puncture. And I think though this was a book question. Which baby is going to need a lumbar puncture for CSF? Only the highest risk and the high risk. This is why I'm telling you, you should know everything about those babies. The mode of delivery, the timing of delivery, what make them high risk. Okay, so again, the highest risk babies. The symptomatic babies, of course, no matter how they were born. Any positive HSV baby by testing, any baby born by vaginal delivery with active initial herpes lesion, any baby was born with from a mother who had initial HSV infection within previous 6 weeks, even he was CS, yes, but there is rupture of membranes, and of course the late presenting mother, a mother who came systemically unwell, or the mother who gave birth and present to us with active primary lesion within 4 weeks of delivery. Allahumma balagh. I have a feeling that this could be exam scenario. So you have to treat the baby as the highest risk. This baby is going to need urgent management. This baby is going to need urgent investigation and, of course, lumbar puncture. Okay. The management. I don't remember exam question asking us as obstetrician about the management of neonates. But it's not easy, not difficult to remember. Okay? It's double the dose of adults. It always has been like the old guideline. Double the dose of disseminated infection in adults. 20 milligram per kg IV without waiting for results. According to the type of infection, the duration of treatment is going to be decided. Local infections, usually like 10 to 14 days. CNS infections can go on for 3 weeks. Disseminated infection until the baby is good and he is going to continue on suppressive dose for 6 months. Okay, guys? Can I ask you some questions to make sure that you got what we have discussed? If a patient got recurrent genital herpes, okay, and now she is having another recurrent episode of genital herpes. She got it in the second trimester. What mode of delivery are you going to offer her? Vaginal delivery. Excellent. Okay. We have a lady with primary episode of genital herpes in the first trimester. What mode of delivery you are going to offer her? Again, vaginal. Excellent. Okay. If the patient got primary herpes in the second trimester, what mode of delivery you are going to offer her? If she's going to have the suppression dose, vaginal delivery. only third trimester or within, especially within 6 weeks of delivery, is an indication for cesarean section. Again, any primary herpes in the third trimester, especially within 6 weeks from the timing of delivery, cesarean section. Okay, so let's say our lady came with her primary episode of HSV at 28 weeks. Okay? At the meeting by 36 weeks, when we decide the delivery mode for normal, uncomplicated pregnancies, we're going to tell her what it's better to go for cesarean section. Okay? What if this woman was, let's say, she was carrying twins, or she had any indication for early delivery? Definitely cesarean. I'm going to consider cesarean section definitely for her because I'm planning to deliver her within 6 weeks from the timing she got the herpes. Okay, let's talk about the suppressive dose. A woman who has primary acquisition of genital herpes in the first or second trimester, when you are going to offer her the suppressive dose. "32 weeks. Excellent. Excellent. The same with recurrent genital herpes. The same with recurrent genital herpes. Okay. Those ladies need the suppression dose to be taken until delivery. The low risk, the recurrent, or the primary herpes in first and second trimester, they need to take the suppressive dose until delivery? No. The one who needs to take the suppressive dose until delivery is the one who got it in the third trimester. There is no time. There is no time. We are trying our best to reduce the viral load. So a cyclovir for 5 days is enough. A cyclovir is taken 3 times per day. Valacyclovir is taken 2 times per day. Both of them for 5 days. Right? Agree? This is very easy to remember. All the doses are here. 2 ladies only are going to need IV acyclovir. Who can remember them? 2 case scenarios are going to need IV acyclovir. One of them is going to take high dose and one of them is going to take usual dose. Excellent, excellent, excellent. The disseminated infection, she's going to take acyclovir IV high dose 10 milligram per kg. And the woman with PPROM, not PROM, PPROM, okay, PPROM, she's going to need a cyclovir also, IV. Those are the main. We have some exceptions, as Dr. Isra is saying. A woman who has the active primary acquisition and she was just discovered to have this primary lesion at the time of labor and she didn't have any previous suppressive dose. Yeah, okay, I'm going to give her the IV. Like Dr. Isra is saying, a woman who had primary herbs around labor and she refused to take the CS, I can give her IV during labor. But you know what? It's not going to be effective. Suppressive dose needs time. So that's it. This is all about the herpes simplex. And I can tell you the update concerning the varicella. It's not a complete update. They just updated the prophylaxis for varicella. That's it. It didn't update everything. Yes, yes, only 5 days. According to the time of presentation, from 32 weeks means whatever the woman has acquired the recurrent infection or the primary acquisition in the first trimester. You are going to give her the suppressive dose from 32 weeks, only for 5 days. No, I was just giving you example, and I'm sorry if it conflicted you. I was just giving you example of someone who is having recurrent infection. But we always focus on vaginal infection more than the oral, of course. Recurrent vaginal, not oral. Okay, where are you, varicella? Where are you, varicella? It would be here somewhere. Yes, here we are. This is the only update in the guideline. It's not an update. Actually, it's updated recommendation regarding the post-exposure prophylaxis. So now instead of giving the IVIG or the VZV or the immunoglobulin of varicella zoster, the first line for prophylaxis would be acyclovir or valacyclovir because of many things. Because of the lack of availability of the immunoglobulins in many hospitals. Many women didn't take the prophylaxis because of this. The immunoglobulins are kind of expensive also. And the oral acyclovir or valacyclovir were good for prophylaxis. Okay, so now we are going to give acyclovir or valacyclovir as the first choice of post-exposure prophylaxis. Please remember, once the woman got rash, no rule for immunoprophylaxis. No rule. What happened happened. We are talking about someone who was exposed to a case with chickenpox and still she is asymptomatic. How can we help her? How can we give her immunity? We used to give her the immunoglobulins. Now the first line is acyclovir or valacyclovir. Now let me see your questions.